Okay, welcome to the infectious disease portion of HTL 302. This is where immunology stops being theoretical and starts showing up on your slides, and sometimes very rudely. In histotechnology, infectious disease isn't about memorizing bugs for fun. It's about recognizing how tissues respond to those organs. Because most of the time, what we're actually seeing under the microscope is the host reaction, not the organism waving at us saying, "Hi, I'm bacteria." As histotechnologists, our role is to preserve organisms and host tissue, choose stains that highlight the right structures, and recognize patterns that suggest infection even when organisms are scarce. So as we go through this chapter, I want you thinking less, what bug is this, and more, what did this bug do to the tissue? That mindset will serve you well in the lab. So let's start with an important truth. Microorganisms are everywhere, on you, in you, around you, and probably judging you. Most of these organisms fall into a category we call indigenous flora, which just means they normally live on us or in us. Commensal organisms, these are the freeloaders. They live on or in the host without causing harm. But they don't really help either. Think of them as roommates who never do dishes, but also never set the house on fire. Histologically, commensals usually don't trigger inflammation, so tissues look normal. Symbiotic organisms, well, these are the good ones, the overachievers. They benefit the host, especially in the GI tract, by helping with digestion, vitamin synthesis, and immune regulation. Fun fact that you didn't ask for, some gut bacteria help synthesize vitamin K, which means they indirectly support blood clotting. So yes, microbes are involved when you stop bleeding. Saprophytes, these organisms break down dead organic material. In the lab world, we mostly care about them when tissue degradation happens before fixation, which can make slides very unpleasant. Pathogens, now we get to the troublemakers. Pathogens cause disease by releasing toxins, invading and damaging host tissues, and triggering destructive immune responses. Infection occurs when a pathogen successfully invades and causes tissue injury. And yes, what we usually see histologically is necrosis, inflammation, edema, and architectural disruption, not the organism itself. Next up, opportunistic infections, which are basically infections that say, I normally wouldn't do this, but since your immune system is busy elsewhere, opportunistic infections occur when the immune system is weakened due to things like HIV, chemical chemotherapy, pregnancy, or bone marrow disorders, or even immunosuppressive drugs. The key concept here is this: the organism is usually harmless until the immune system drops the ball. So Clostridium perfringens, this organism normally lives in the GI tract, minding its own business. But under the wrong conditions, it releases potent toxins that cause tissue necrosis, sometimes rapidly. Histologically, this can look dramatic. So extensive necrosis, minimal inflammation early on, even gas bubbles separating tissue planes. Seriously. Staphylococcus aureus, this is normal skin flora, totally fine until there's a break in the skin. And then suddenly we can have abscess formation, neutrophilic infiltrates, and tissue destruction. From a histotech perspective, opportunistic infections often show disproportionate tissue damage relative to the number of organisms present. That's a big clue. Now let's talk about how infections spread, because organisms don't teleport, despite how it sometimes feels in the lab. A vector is simply a method of transmission. So common vectors include food and water for classic GI infections, dirty fingers, still undefeated, fecal contamination, so wash your hands, seriously, flea or insect bites, body fluids, and something called fomites, which are inanimate objects. Some worthless but useful knowledge: your phone is a fomite, so is your lab pen, and probably the keyboard you're using. From a tissue standpoint, the route of entry matters because it influences where the lesions occur, which tissues are affected first, and the type of inflammatory response. For example, inhaled pathogens, you have lung parenchyma involvement. Ingested pathogens, you'd have GI mucosal injury. Vector-borne infections, we would see vascular and systemic patterns. Finally, let's talk about organisms that play the long game, latent infections. These organisms lie dormant without causing active disease, sometimes for years. The herpes simplex virus, also called HSV. HSV hangs out in nerve ganglia, basically hiding until stress, illness, or immune changes wake it up. Histologically, during reactivation, you may see ballooning degeneration, some multinucleated giant cells, even some nuclear inclusions. Also, Plasmodium, the malaria parasite, can remain dormant in liver cells. When it reactivates, it causes systemic disease, but histologically, early changes can be subtle. There's carriers. A carrier harbors an organism without showing symptoms, but can still spread it. So from a public health perspective, it's terrifying. From a histology perspective, it's very tricky. Carrier states often show minimal tissue reaction, which is why correlation with clinical history is so important. If there's one takeaway from these first 5 slides, it's this. In infectious disease, histology is about patterns of tissue injury, not just identifying the organism. You're training your eye to recognize necrosis patterns, inflammatory cell types, distribution and architecture changes, subtle clues that suggest infection even when organisms are scarce. And yes, we will absolutely build on this. Okay, so welcome to the freeloaders. When we talk about parasites, we're talking about infectious agents that cannot complete their life cycle without the host doing the heavy lifting. These organisms are not interested in mutual benefit. This is not a partnership. This is you pay rent and I wreck the place. The first one we have are helminths. Helminths are parasitic worms. They derive from nutrition directly from the host's blood or tissues. From a histology standpoint, this matters because they provoke chronic inflammation, not the dramatic acute stuff you see with bacteria. In tissue sections, helminth infections often show eosinophil-rich infiltrates, which is your biggest clue, granulomatous inflammation, and fibrosis over time due to chronic immune activation. Schistosomes are a great example. Their eggs, not the worms themselves, are what cause the most tissue damage. In histologic sections, you may see granulomas forming around eggs, distorted vascular structures, or even progressive fibrosis. Fun but useful fact, if you see eosinophils everywhere and no obvious bacteria, start thinking parasites before you panic. Okay? Then we have viruses. Viruses are minimalist criminals. They bring almost nothing with them and force the host cell to do all the work. Histologically, viral infection often causes cytopathic effects like nuclear enlargement, chromatin margination, and inclusion bodies. Also, cell rounding or Centia formation, apoptosis rather than necrosis, so a much cleaner cell death. From a histotech perspective, viral damage is often subtle and pattern-based, not obvious pus and destruction. Then we have intracellular bacteria. Some bacteria, like chlamydia, behave more like viruses than bacteria. They live inside host cells, protected from many immune defenses. Histology clues include intracytoplasmic inclusions, minimal extracellular inflammation early on, and chronic epithelial damage over time. The bottom line is this: if the bug is living inside the cell, The cell architecture tells the story, not the organism itself. Now let's talk about the system that keeps all of this from turning into a microbial free-for-all. Immunity is protection from infectious pathogens. But in histology, what we really care about is how that protection reshapes tissue. The immune system is not subtle. It remodels tissue, it recruits cells, alters vasculature, and leaves clues everywhere. There are two major arms of immunity, and you already know them. But now we're going to look at them through a microscope lens, not a textbook diagram. Think of innate immunity as your lab's emergency spill response. It's fast, it's nonspecific, it does not remember what happened last time. Innate immunity includes physical barriers like the epithelium, phagocytes in the form of neutrophils and macrophages. We have NK cells or natural killer cells, they're also referred to. We have complement. Histologically, innate responses show up as edema, neutrophil infiltration, vasodilation, and tissue swelling and architectural distortion. It's messy, it's fast, it's effective, but it's not precise. Now compare that to adaptive immunity, which is more like a case review committee. It takes longer, it's highly specific, and it remembers everything. Adaptive immunity involves B lymphocytes in the form of antibodies, T lymphocytes, so cytotoxicity and signaling. Histologically, adaptive responses show lymphocyte dominant infiltrates, organized immune structures, chronic inflammation patterns, and tissue remodeling and fibrosis. So key takeaways for us histotechs are neutrophils equal acute inflammation, lymphocytes equal chronic or adaptive. Okay, if you can identify the dominant cell type, you're already halfway to understanding the disease process. Slide looks intimidating, but don't panic. No one is asking you to memorize this list. What matters here is why these diseases are reportable and how they damage the tissue. Many of these infections cause severe inflammation, tissue necrosis, long-term organ damage, and are public health risk. From a histology standpoint, different pathogens create signature patterns. Tuberculosis, we'll see granulomas with caseous necrosis. Syphilis, we will see plasma cell-rich infiltrates. HIV/AIDS, we're going to see lymphoid depletion over time. And with malaria, we will see parasitized red blood cells and vascular congestion. So worthless but fun fact, some of the most devastating infections are microscopically subtle early on. That's why clinical correlation matters. Slides do not exist in a vacuum. Statistic that surprises people every time. Upper respiratory tract infections account for over 80% of acute infections. That means most infections don't destroy organs. They irritate epithelium, trigger inflammation, and then resolve. Histologically, upper respiratory infections often show epithelial damage, mucosal edema, increased goblet cells, and inflammatory infiltrates without deep tissue destruction. Treatment is usually supportive because many are viral. Antibiotics don't fix viruses, no matter how badly patients want them to. Now, the fun epidemiology fact, the most commonly reported infection is chlamydia. Why this matters histologically? Often asymptomatic, it causes chronic epithelial injury, and it leads to scarring, fibrosis, and long-term tissue changes. Histology doesn't just show what's happening now, it shows what's been happening quietly for years. And that, friends, is why what you do at the bench actually matters. On this slide, we're focusing on how infections typically present clinically. And an important point here is that most infections do not announce themselves clearly at first. Many patients present with nonspecific symptoms, meaning symptoms that could be caused by a wide range of conditions. These include fever, an elevated heart rate, muscle aches, fatigue, and a general sense of malaise. From a diagnostic standpoint, these symptoms tell us something is wrong, but not what is wrong. Some infections, however, do have more specific clinical clues. For example, the characteristic rash seen with measles or chickenpox can strongly suggest a viral etiology. Severe lower right quadrant abdominal pain accompanied by anorexia points us toward appendicitis, often associated with bacterial infection. As histotechnologists, it's important to remember that these clinical signs are often what prompt biopsy, surgical excision, or laboratory testing, which means we are seeing the tissue consequences of these processes, not just the symptoms themselves. Diagnosing infection requires integrating clinical findings with laboratory data, and this slide highlights some of the most common diagnostic tools. Basic measures like body temperature provide early clues, but laboratory testing adds specificity. A white blood cell count can indicate the type of infection based on which cell population is elevated. Increased neutrophils suggest a bacterial infection. Lymphocytes are more commonly associated with viral infections, and elevated eosinophils point towards parasitic involvement. From a histology and pathology perspective, direct detection methods are especially relevant. Gram stains and wet preparations allow visualization of organisms, while bacterial and fungal cultures identify vital pathogens and guide treatment decisions. Antibiotic susceptibility testing is critical for determining effective therapy, and molecular testing, particularly PCR-based methods, has become essential for detecting viral infections. All of these tests help correlate what is happening at the tissue level with what is seen clinically and microbiologically. This slide highlights an important and sometimes overlooked concept. Chronic infection can contribute to cancer development or neoplasia. Certain organisms promote long-term inflammation, cellular turnover, and genetic instability. For example, Helicobacter pylori, or also called H. pylori, infection is strongly associated with gastric lymphoma and gastric adenocarcinoma due to its persistent mucosal inflammation. Human papillomavirus, or HPV, is another well-known example, contributing to cervical cancer and several other anogenital and oropharyngeal cancers through viral oncogene expression. Parasitic infections involving the bile ducts can lead to cholangiocarcinoma, particularly in endemic regions. For histotechnologists, recognizing infection-associated neoplasia reinforces why accurate tissue processing, staining, and interpretation are critical. We are often identifying the long-term consequences of infectious disease. Sexually transmitted infections, or STIs, represent one of the most common reportable infectious diseases in the United States. Chlamydia, gonorrhea, and syphilis consistently rank among the highest in incidence. A key challenge with STIs is that many individuals are asymptomatic, allowing infection to persist and spread without detection. From a laboratory standpoint, this means diagnosis often relies heavily on screening tests, molecular assays, and tissue sampling rather than overt clinical symptoms. Understanding STI pathology is essential, not only for diagnosis, but also for recognizing associated inflammatory changes, epithelial damage, and long-term sequelae that may appear in tissue specimens. Chlamydia is caused by Chlamydia trachomatis, an obligate intracellular gram-negative bacterium. Because it must replicate inside host cells, it behaves differently than many free-living bacteria. It is the most common bacterial sexually transmitted infection worldwide, and one of the most frequently reported infections overall. Clinically, chlamydia can cause epididymitis, prostatitis, pelvic inflammatory disease, pharyngitis, conjunctivitis, and perihepatic inflammation. Importantly, it can be entirely asymptomatic in both men and women, which contributes to delayed diagnosis and chronic inflammation. In tissue samples, chlamydia infection is associated with inflammatory infiltrates and epithelial damage rather than easily viable organisms, making laboratory testing and clinical correlation essential. This is a prime example of how understanding microbial behavior helps us interpret histological findings accurately. On this slide, we are focusing on gonorrhea, a common and clinically significant sexually transmitted infection. Gonorrhea is caused by Neisseria gonorrhoeae, which is a gram-negative diplococcus. Morphologically, these organisms are often described as kidney-shaped diplococci, and they are frequently found inside neutrophils on stain smears. That is a key diagnostic clue. This organism primarily infects the mucous membranes of the reproductive tract in both men and women, but it can also affect the rectum, pharynx, and conjunctiva. If left untreated, gonorrhea can lead to serious complications, including pelvic inflammatory disease, infertility, and decimated gonococcal infection. Histotechnology connection here is that although gonorrhea is most often diagnosed using molecular testing or culture, histologic specimens may show acute inflammation with abundant neutrophils, especially in mucosal tissues. Recognizing patterns of purulent inflammation helps support clinical correlation. Syphilis is caused by Treponema pallidum, a sphericete bacterium. Because this organism is extremely thin, it does not stain well with routine H&E and is classically demonstrated using silver stains, such as the Werthenstari. Syphilis is a chronic, multi-stage disease, and its manifestations change over time. Primary syphilis presents with a painless chancery at the site of infection. Secondary syphilis is marked by systemic spread, producing skin rashes and mucosal lesions known as condyloma lata. Tertiary syphilis can involve the cardiovascular system, central nervous system, or form granulomatous lesions called gummas. Histotechnology connection. Syphilitic lesions often show plasma cell-rich inflammatory infiltrates and obliterative endarteritis. Special stains are critical when syphilis is suspected, but organisms are not visible on routine stains. Congenital syphilis occurs when Treponema pallidum is transmitted from mother to fetus through the placenta. Without treatment, congenital infection carries a very high mortality rate, with approximately 25% of affected infants dying if untreated. Late manifestations of congenital syphilis include interstitial keratitis, Hutchinson's teeth, um, and eighth cranial nerve deafness. These findings reflect chronic inflammatory damage occurring during critical stages of development. Histotechnology connection. Placental tissue may show inflammatory changes, and fetal tissues can demonstrate widespread involvement. Awareness of congenital infection patterns is important when examining placental or pediatric specimens. Bacterial infections cause disease through several well-defined mechanisms. First, bacteria may evade destruction by phagocytosis, allowing them to persist in host tissues. Second, motility structures such as cilia or flagella help organisms migrate and colonize tissues. Third, bacteria can produce enzymes that degrade host tissue and facilitate spread. Finally, many bacteria produce toxins, which are responsible for significant tissue injury and systemic effects. Bacterial infections are often classified by behavior or source. So we have pyogenic bacteria, which produces pus. We have anaerobic bacteria, which thrive in low oxygen environments. And we have zoonotic infections, which is transmitted from animals to humans. Histotechnology connection here is that different bacterial mechanisms lead to different histological patterns, from abscess formation to necrosis. Understanding these mechanisms helps explain why tissues look the way they do microscopically. Pyogenic bacterial infections are characterized by pus formation, which consists primarily of dead neutrophils, bacteria, and necrotic tissue debris. Some common causes include staphylococcal infections, streptococcal infections, gram-negative rods such as E. coli, Klebsiella, Pseudomonas, or Enterobacter, also Shigella, Salmonella, and Yersinia. Other important organisms include Neisseria meningitis, Legionella pneumophila. These infections often produce acute inflammatory responses, abscesses, or tissue destruction. The histotechnology connection here is that pyogenic infections are among the most common causes of suppurative inflammation seen on histological slides. Recognizing dense neutrophilic infiltrates, liquefactive necrosis, and abscess architecture is essential for accurate interpretation. All right, so let's talk about Staphylococcal aureus, or as I like to call it, the overachiever of bacteria. This organism does a lot, and almost none of it is helpful to us. Staphylococcus aureus is a gram-positive coccus that forms clusters that look like grapes. If you ever forget that, just remember staph snacks in bunches. It produces multiple toxins, which explains why it can cause everything from minor skin infections to life-threatening systemic disease. It is incredibly versatile, and unfortunately for us, it's very good at surviving. Clinically, Staph aureus is associated with skin lesions such as boils, carbuncles, impetigo, and scalded skin syndrome. But it doesn't stop at the skin. This organism can cause abscesses, sepsis, osteomyelitis, pneumonia, endocarditis, food poisoning, and even toxic shock syndrome. Basically, if there's tissue, staph is interested. From a pathology standpoint, we often see redness, swelling, heat, and pain. Fever, leukocytosis, and purulent drainage. And yes, pus is not subtle. If you see thick yellow-white material, staph should immediately be on your mental short list. And here's a worthless but useful fact. About 30% of healthy people are colonized with Staph aureus on their skin or in their nose at any given time. So congratulations. Statistically, one of you brought staph to the lecture today, if we were in person. Let's zoom in on one of the more dramatic and frankly heartbreaking manifestations of Staph aureus, which is staphylococcal scalded skin syndrome, also known as Ritter disease. This condition occurs commonly in infants and young children and is caused by exfoliative toxins produced by certain strands of Staph aureus. These toxins target desmoglein 1, which is critical for holding epidermal cells together. The result? The skin literally falls apart. Clinically, it starts as a sunburn-like rash that spreads very rapidly. It progresses into fragile bullae that rupture easily, leading to partial or total loss of the superficial epidermis. Histologically, this is important. The cleavage plane is within the epidermis, not at the dermal-epidermal junction. That detail matters, and yes, it's exam-worthy. Analogy time here. Think of the epidermis like a brick wall held together by mortar. The toxins dissolve the mortar, the bricks don't disappear, the wall collapses anyway. Despite how severe it looks, the skin is sterile. The damage is toxin mediated, not due to direct bacterial invasion of the skin, which is terrifying but also fascinating. Now we get to the part where microbiology becomes a little too real. Antibiotic resistance. Methicillin-resistant Staphylococcus aureus, or MRSA, MRSA, is resistant to nearly all penicillins and cephalosporins. This isn't because the antibiotics are weak, it's because MRSA is stubborn and genetically clever. MRSA alters its penicillin binding proteins, meaning the antibiotic can show up and just not work. From a lab standpoint, this is where susceptibility testing becomes critical. You cannot assume coverage. You must test. MRSA exists in healthcare associated settings and community settings. So no, this is not just a hospital problem, this is an everywhere problem. A fun but alarming fact is that MRSA can survive on dry surfaces for weeks to months. So if you've ever wondered why infection control was so intense, this is why. And as for an histology tie-in, antibiotic resistance doesn't change morphology, but it absolutely changes the outcomes. Same organism, very different patient story. Let's switch gears to alpha hemolytic streptococci, which partially lyses red blood cells, giving us that classic greenish discoloration on blood agar. First up, Streptococcus pneumoniae, also known as pneumococcus. This organism is the most common cause of pneumonia, but it also causes otitis media, meningitis. It's encapsulated, which helps it evade phagocytosis. And yes, capsules matter. Then we have Streptococcus viridans, which lives happily in the oral cavity. Most of the time, it's just minding its own business, but if it enters the bloodstream, for example, after dental work, it can cause endocarditis, particularly on damaged heart valves. An analogy is that viridans is like a quiet neighbor who becomes a problem only when they show up uninvited at the wrong house. Some worthless knowledge that sticks. The word viridans literally means green, which is fitting because alpha hemolysis looks green, and microbiologists love consistency. Finally, we arrive at beta hemolytic streptococci, which causes complete hemolysis. There is no subtlety here. The most important player is group A streptococcus or Streptococcus pyogenes. This organism is responsible for acute pharyngitis, scarlet fever, impetigo, cellulitis, and even necrotizing fasciitis. Yes, flesh-eating bacteria is not a myth. Clinical manifestations include heat, redness, swelling, and pain. Again, fever, leukocytosis, we have rapid tissue destruction, and toxic shock. And here's where pathology gets especially interesting. Some of the most serious complications occur after the infection is gone. The immune-mediated sequelae include rheumatic fever or post-streptococcal glomerulonephritis. So the bacteria leave, but the immune system keeps swinging. A scarlet fever fun fact is that strawberry tongue everyone remembers. That's disquamination of the white coating, revealing hyperemic papillae underneath. Not all damage is direct. Sometimes the immune system is the real problem, which, spoiler alert, is a theme you'll see a lot in pathology. All right, let's talk about something almost everyone has had at least once. Strep throat, the bacterial version of why does swallowing feel like broken glass? Strep throat is caused by group A streptococci, specifically Streptococcus pyogenes. These are beta hemolytic gram-positive foci that love the upper respiratory tract, especially the tonsils. Pathologically, what's happening here is acute inflammation. The tonsils become swollen and edematous, and you'll often see punctate abscesses within the tonsillar crypts. Those white patches people notice, that's neutrophils, fibrin, and bacteria throwing a party you were not invited to. Cervical lymph nodes often enlarge because the immune system is doing exactly what it's supposed to do. It's filtering lymph and mounting a response. Unfortunately, that response also makes the throat feel tight, painful, and angry. And here's the part we take seriously. Significant swelling can narrow the airway. That's why severe cases, especially in children, are not something we ignore. This is not just a sore throat, it's an acute inflammatory process that becomes dangerous if untreated. A fun but useful fact, if someone has fever, tender lymph nodes, tonsillar exudate, and no cough, that's a classic bacterial red flag. Viruses usually bring a cough to the party. Now we're heading south, literally, into the world of gram-negative enteric bacteria, which are bacteria that either live in or love the gastrointestinal tract. This group includes names you've already heard and will hear forever: E. coli, Klebsiella, Pseudomonas, Enterobacter, Salmonella, Shigella, and Yersinia. From a histology and pathology standpoint, these organisms are inflammatory powerhouses. They cause disease by invading tissue, triggering neutrophilic inflammation, and releasing endotoxins. Clinically, these infections can show up in a lot of ways. So enteric infections causing diarrhea, wound infections, especially in hospital settings, and peritonitis when gut bacteria escape the GI tract. Necrotizing pneumonia, particularly with Klebsiella and Pseudomonas. We have neonatal meningitis, especially with E. coli. Histologically, we're often seeing acute inflammation, tissue necrosis, and sometimes abscess formation. These organisms don't politely stay where they belong. Once barriers break down, things escalate fast. So worthless but memorable knowledge is E. coli is both your best gut friend and one of your worst enemies, depending on where it ends up. So location does matter. Now let's talk about how bacteria cause chaos without even being present. Toxins. There are two big categories here: exotoxins and endotoxins, and they behave very, very differently. Exotoxins are proteins actively secreted by bacteria, usually gram-positive, and they are extremely potent. These toxins have very specific targets and dramatic effects. Some classic exotoxin producers include Clostridium tetani, which is tetanus, aka lockjaw; Clostridium botulinum, which is botulism, which causes paralysis; Clostridium perfringens, which is gas gangrene. Then we have Vibrio chloride, which is massive electrolyte loss. And we have Bacillus anthracis, which is anthrax. These toxins are like precision weapons. A small amount creates massive damage. Endotoxins, on the other hand, are structural components of gram-negative bacteria cell walls, specifically the lipid A portion of LPS. They're released when bacteria die or divide, and instead of targeting one system, they trigger widespread inflammation. Endotoxins cause fever, hypotension, and shock, not because they're precise, but because they push the immune system into overdrive. A student-friendly analogy is exotoxins are kind of like the snipers, and endotoxins are the grenades. This table is one of those exam-friendly, board-friendly, life-friendly comparisons. So let's walk through it like adults. Exotoxins are mostly gram-positive bacteria. They are actively secreted. There are proteins with specific cellular targets, and they are heat labile, which usually break down with heat. They are highly toxic and can be converted into toxoids, which is how vaccines like tetanus work. Endotoxins are from gram-negative bacteria. They are part of the bacterial cell wall. They are released during cell death or division. They are heat stable. They are less potent individually, but dangerous systemically. They cannot be made into toxoids. The biggest takeaway? Exotoxins cause specific diseases. Endotoxins cause systemic misery. If a patient is febrile, hypotensive, and spiraling into septic shock, endotoxin is often involved. Not because it's fancy, but because it's relentless. And a tiny pearl here is you don't neutralize endotoxin easily. The best treatment is supportive care and killing the bacteria, not antitoxin therapy. Finally, let's talk about zoonotic infections, diseases we politely borrowed from animals and absolutely regret. These infections cross species barriers and usually involve vectors like ticks, fleas, lice, or contaminated food. A few highlights, we have Lyme disease from the Borrelia burgdorferi, which is transmitted by ticks. We have salmonellosis from undercooked poultry and eggs. And we have plague from Yersinia pestis, which is spread by fleas on rodents. There's also tularemia, which is from rabbits and ticks. There's brucellosis from unpasteurized dairy, and there's Rocky Mountain spotted fever from ticks. Pathologically, these diseases often involve vascular injury, systemic inflammation, and multi-organ involvement. They don't stay local. Once they enter the bloodstream, they travel. And yes, rabies and prion diseases get honorable mentions here because biology enjoys being terrifying. The big concept to remember is exposure history. When clinicians ask about animals, travel, or weird hobbies, it's not just small talk, it's actually detective work. Some worthless but fun knowledge here is the plague still exists. It's just moved from medieval Europe to prairie dogs in the Southwest. Same drama, just a different setting. All right, let's slow down just a bit here because Lyme disease is one of those topics that students think they know until pathology enters the picture. Lyme disease is a common arthropod-borne illness caused by the spirochete Borrelia burgdorferi. Okay, when you hear spirochete, picture a thin, corkscrew-shaped organism. It's flexible, sneaky, and very good at moving through tissues. These organisms are not flashy under routine stains and often require special techniques or serologic testing to confirm infection. Transmission occurs through the Oxidus deer ticks, which act as the delivery system, not the cause themselves. The bacteria live in rodents and are passed to humans during a prolonged tick attachment. This is why early tick removal matters. Time really does equal exposure here. Clinically, Lyme disease can be localized or decimated. Early disease may involve a characteristic skin lesion, erythema migrans, but pathology students should pay attention to what comes later. If untreated, Lyme disease has a strong tendency to cause persistent chronic arthritis, particularly involving large joints like the knee. From a pathophysiology standpoint, this chronic inflammation is driven by immune-mediated tissue damage rather than ongoing high-level bacterial load. So translation, even when the bacteria aren't easy to find, the immune system may still be causing problems. A histotech connection here is that chronic inflammatory changes, synovial thickening, and lymphoplasmatic infiltrates may persist long after infection. This is a great example of why the bug is gone does not always mean the disease is over. Okay, this slide is intentional. At this point in the lecture, you've covered multiple bacterial specimens, toxin mechanisms, inflammatory patterns, systemic complications, zoonotic transmission, and honestly, that's a lot. And pathology doesn't reward brushing, it rewards processing. So this slide is your official permission to take a breath. Think of this like trimming a block before sectioning. If you rush it, you'll pay for it later. The same is true when learning this dense material. Pausing helps your brain organize what you've just taken in. Here's what I want you to do before moving on. Stretch your hands, look away from the screen for 30 seconds, take one actual intentional breath. No quiz questions come from this slide, but your ability to survive the rest of the lecture absolutely depends on moments like this. We're about to move into part 2, where everything you've learned so far starts to connect across systems. And you're doing exactly what you should be doing, showing up, staying engaged, and building clinical reasoning one step at a time. So, all right, when you're ready, let's move on to part 2.